Morning, Kaval.
Good morning. How are you?
Good. Morning, Srinivas.
Morning.
Sanjay, are you there? Or is it Sudikshna? Hello. Are we live?
Sir, it's live now. You can start. Ma'am, you can
Okay.
start now.
So good morning, everyone. This will be the second session. We talked about the antibiotics in sepsis, how to select the last week. And today I'm here again to talk about the drug dosing during extracorporeal therapy. This will not be exactly focused on the antibiotics, but generally we'll talk about how we plan about the drug dosing during extracorporeal therapy. Myself, Dr. Kamalpreet, I'm from Ludhiana, and I'm happy to be on the HICS platform to have a talk on drug dosing during extracorporeal therapy. Well, I think all of us almost are using extracorporeal therapies in some form or the other in almost all ICUs across the country. And there is a definite potential for the altered PK/PD of drugs because of the therapy itself, which interferes with the pharmacokinetics and dynamics of the drugs, and the critical illness wherein the therapy is actually needed. So all the alterations they actually might contribute to the therapeutic failure of the drugs. The drug toxicity can occur, and even later on, the antimicrobial resistance becomes a problem. So the usually used drugs are the sedatives or vasoactive agents, which can be actually titrated to the effect. So we can just have the targets and titrate the drugs accordingly. But when we talk about the antimicrobials, they are not actually any specific targets for those drugs. And they're generally guided by the laboratory surrogates, and we do not have any real-time feedbacks. So herein we need to understand the complex interactions between the ECMO therapy and the drugs so as to optimize our therapy. So when we talk about the drug pharmacotherapy in the extracorporeal circuits, there are multitude of factors which come into play. There can be the patient-related determinants, the drug-related determinants. The patient-related determinants usually are the critical illness, the volume status, the fluid resuscitation we go in for, or the co-medications. The drug-related determinants that are the pharmacological characteristics of the drugs per se, the circuit-related determinants, what are the factors. We'll be just discussing all these factors in next 30 minutes or so. Then there are the drug-patient interactions and the drug circuit interactions, all of which actually contribute to the variable pharmacokinetics and dynamics of the drugs. So let's start with the effects of extracorporeal therapy per se on how they affect the pharmacokinetic, drug pharmacokinetics are altered. So the primary things which affect the drug pharmacology is the sequestration of the drugs into the circuit, the volume of distribution, which becomes large during extracorporeal therapy, and the drug clearance is also altered. Beyond this, the systemic inflammation resulting from prolonged use of extracorporeal circuit, these can all complicate the situation and alter the drug requirements during the extracorporeal therapy. So when we start with the extracorporeal therapy, the first and foremost thing we go in for is the circuit priming. And the large surface area of the circuit, it needs large volumes which go into the plasma of the patient and leading on to acute hemodilution and increasing the volume of distribution of the drugs. And it certainly decreases the plasma concentration because of the hemodilution. Further in, there is depletion of the plasma proteins. Once the hemodilution occurs, the plasma proteins decrease, primarily the albumin, and decreasing the tissue and the plasma protein binding, thereby increasing the plasma concentration of the drugs. But this generally is transient because we further supplement with albumin, the blood products, and therein again the hemodilution occurs, which can also again lead on to decrease in the concentration of the drugs. So these pharmacological impact of the circuit priming actually depends upon the apparent volume of distribution of the drugs, what type of drug it is. We'll be further talking about this. the degree of protein binding of the drugs, and the extent of equilibration that can occur between the tissue and plasma concentration once we initiate the extracorporeal therapy. Furthermore, there occurs drug loss due to absorption of the drugs due to the circuit. This is more so associated with the lipophilic and the highly protein drugs. More lipophilic the drug is, more absorption will be there. And highly protein bound drugs again have a more sequestration. This sequestration, which is actually the drug can be trapped into or absorbed onto the circuit, this leads on to increase in the elimination half-life, the drug clearance is decreased, and the volume of distribution again increases. So all these again pharmacokinetic effects, they lead on to decrease in the plasma concentrations of the drugs. So this sequestration can be influenced by the circuit factors per se. The circuit factors, the oxygenator materials, they say that more hollow fiber membrane oxygenators, they have lesser of absorption for almost all the drugs, again more pronounced for the lipophilic drugs. Then the types of conduit tubings used, like what material is used, the absorption onto the specific materials also varies. The circuit age, we'll be just talking about how the circuit age affects the drug sequestration, and the composition of the priming solution, like whether they are water soluble or the colloids or the crystalloids being used. But although none of the studies have shown significant evidence, because usually we use normal saline for the priming, and that has not shown much effects on the drug sequestrations. So the complexity further is, like I talked about the circuit age, the adsorption, that is the drug sequestration, it decreases over time because of the saturation of the binding sites. Whatsoever binding sites are there for the drug sequestration, that those get saturated, and thereby once we are targeting the adsorption phenomenon, we need to have a higher dosing continuously. But this higher dosing continuously may actually lead to drug toxicity because of the binding site saturation. Contrary to this, the circuit actually may act as a reservoir and redistribute the sequestered drug back into the patient, even once we have stopped the drug administration per se. And this actually might also lead to prolonged undesirable pharmacological effects even after the drug administration has been stopped. So there's a lot of complexity involved. Then further beyond the circuit things, the blood flow, the non-pulsatile flow, which is there in the VA ECMO, it further leads on to altered tissue perfusion, decreased capillary circulation, and the decreased aerobic metabolism occurs. All the organs, they sense this non-pulsatile flow, like kidneys, they interpret that it can be hypotension itself and activating the RAS system, decrease in the urine production, impaired excretion of the drugs per se, and increased volume of distribution of the drugs occurs. So regional blood flow changes in the liver, again, the drugs which have a high extraction ratio, and primarily therein the drug clearance is affected, and it may lead to decreased clearance of the drugs. The pulmonary blood flow, again, the decreased pulmonary blood flow affects the sequestration and metabolism of mainly the sedatives and the analgesics, which are the drugs affected by the lungs. And the systemic inflammatory response to the ECMO can lead on to autonomic, endocrine, and local cytokine factors, which again can alter the tissue distribution of drugs and their clearance. So in nutshell, the ECMO may alter the apparent volume of distribution of drugs, primarily by hemodilution from the priming solutions, the drug sequestration. Beyond that, the ECMO-related physiological changes, like there are changes in the blood pH, which can itself affect the alteration, the drug distribution, the PK might be changed, and protein binding, they all are affected. And the changes associated with systemic inflammation, they can potentially lead to increase in the volume of distribution of mainly hydrophilic drugs. So drug clearance can be either ways. The lower drug clearance that leads on to accumulation of drugs or metabolites due to renal and hepatic hypoperfusion, which can be actually offset by the initial increase in clearance due to increase in the cardiac output secondary to SIRS the aggressive fluid therapy we are giving, or the inotropic support. So it is very much dicey, like it can be the lower drug clearance or the increased in the drug clearance, especially in the early phase of the extracorporeal therapy. Now, the physicochemical characteristics of the drugs, they also affect the drug sequestration. Mainly, the drug sequestration is affected, and the factors affecting are the molecular size of the drug, the degree of ionization, that is what we term as the pK of the drug, the lipophilicity, which it is mentioned as a log P of the drug. Higher is the log P, that means higher is the degree of lipophilicity, and more sequestered the drug will be, and more extraction by the ECMO circuit will be there, and lesser will be the plasma concentration of the drug. The plasma protein binding, they may determine the degree of drug sequestration, especially for drugs which have similar lipophilicity. So let's see what we mean by it. Higher is the volume of distribution, right? So if there's a large volume of distribution, the loading dose we have to increase. That means the drug concentration is decreasing, and this is more important for the hydrophilic drugs, because they initially have a lower volume of distribution. The hydrophilic drugs, they're usually not, because of the hydrophilicity, they do not cross the plasma membranes, and they remain more so in the vessels only. So with increase in the volume of distribution, which we have already discussed in the extracorporeal therapy, so we need to have increase in the loading doses. When we talk about the drug sequestration, again, I've just told you that we talk about the log P. That is, higher is the log P, that means more lipophilic the drug is. And further, if the log P, that means the more sequestered the drug is. But if with the same log P, then we look at the protein binding. So higher is the protein binding in more lipophilic drugs, higher will be the maintenance dose of the drug. So we need to increase the maintenance dose of the drugs. So hydrophilic antibiotics, we know the usually routinely used beta-lactams, the aminoglycosides, the glycopeptides, they are all hydrophilic drugs, and they have a low volume of distribution, I've told you, and predominantly they are renally excreted. While during routine critical illness, again, there is increased volume of distribution, and the renal clearance might be higher with when we talk about the augmented renal clearance, or lower if there is a renal organ dysfunction, and leading on to there can be decreased renal clearance. So the lipophilic drugs, fluoroquinolones, macrolides, and tigecycline, they are the lipophilic drugs having higher volume of distribution and predominantly having hepatic clearance. But routinely, the volume of distribution is not altered during critical illness for the lipophilic drugs, and clearance again depends upon the hepatic function. Not only the hydrophilicity or the lipophilicity, what is the another pharmacodynamic parameter which is important is whether we are dealing with the time dependent or the concentration dependent antibiotics. We all know the beta-lactams, all these penicillins, cephalosporins, carbapenems, they are the time dependent antibiotics, wherein the pharmacodynamic target should be time for which the drug concentration remains above the minimum inhibitory concentration. So when we talk about the extracorporeal therapy, for these drugs, if the patient is on extracorporeal therapy, we have to give a loading dose. And along with that, we need to give a continuous or extended infusion. While if the patient is not on extracorporeal therapy, only a bolus infusion for around 1 hour or 1 to 2 hours is enough. But when we talk about the concentration-dependent antibiotics like the aminoglycosides, the pharmacodynamic target is the peak to MIC, or what is the concentration achieved once we give the drug. So if again these concentration-dependent antibiotics, the patient is on extracorporeal therapy, we have to give a bolus infusion to achieve the peak concentration, as we routinely do for other or the patients. But if the patient is not on extracorporeal therapy, again, bolus infusion after the dialysis is completed, and supplemental dose may be required if drug is given during the treatment. During the extracorporeal therapy, ongoing therapy is there, so we might need to give a supplemental dose. So to summarize this about the hydrophilic, the lipophilic drugs, during the initial phase, once we start with the extracorporeal therapy, we have to increase the loading dose, as we have already discussed, because the volume of distribution increases for these drugs. So we have to give the increased loading dose, especially for the concentration dependent drugs, and high loading dose before, for time dependent drugs. Again, before starting, we have to give a higher loading dose. For the lipophilic drugs, we do not need to alter the loading doses. The loading doses have to be weight-based, especially for the obese patients. During the early maintenance phase, like initial 48 hours of the extracorporeal therapy, again, consider continuous or prolonged infusion for time-dependent antibiotics and adjust the drug dosing according to the renal function. And we can use extended dosing intervals for concentration-dependent drugs. For the lipophilic drugs, we have to adjust the drug dosing as per the hepatic function. And if the hepatic dysfunction is there, we have to decrease the doses. In the late maintenance phase, that is beyond the 48 hours, for the hydrophilic drugs, we again adjust drug dosing as per the renal function. But for the lipophilic drugs, we have to adjust drug dosing according to the hepatic function. And we might need to, if it is a lipophilic drug with high protein binding, we might need to increase the maintenance doses for these drugs. For all drugs, during the maintenance phases, what is important is the therapeutic drug monitoring. Whenever available, we should go in for this. And for the late maintenance phases, especially drug dosing should be adjusted according to the minimum inhibitory concentration results. And we always need to look for the antibiotic-related toxicity. So beyond the challenges of the ECMO factors per se, there are certain patient factors which we know always affect our drug pharmacokinetics and dynamics for the critically ill patients, which can be in the form of systemic inflammation, the hemodilution, which occurs because of our fluid resuscitation, the bleeding and the transfusions, which we are giving, the organ dysfunction associated, and if the patient is on renal replacement therapy beyond the ECMO therapy. So when I think everybody is aware of that when we talk about the sepsis, we can have the leaky capillaries, there's altered protein binding, and even we talk about the augmented renal clearance, which will all affect the pharmacokinetics of the drugs. And they can be the increased volume of distribution, increased clearance because of augmented renal clearance. And they all will lead on to lower plasma concentrations of the drugs and treatment failure. Associated with sepsis is the organ dysfunction, which can be the renal dysfunction commonly associated, or it can be even a hepatic dysfunction, and decreased clearance of the drugs will be there, which can actually lead on to higher plasma concentrations. Beyond that, if the patient is on renal replacement therapy along with the extracorporeal therapy, the drug characteristics which routinely affect the clearance are there. The molecular size, we have already talked about all these things. So smaller molecular weight drugs, the higher more hydrophilic drugs, and patients drugs having low protein binding, they're easily passed through. So renal replacement during renal replacement therapy, the clearance is more. So we need to increase the drug doses. And the dialysis filter characteristics, that is what is the filter composition, the pore size, and the surface area, again, they will affect. And not only this, the dialysate and the ultrafiltrate rates, the clearance will be higher if we have kept the higher blood flow rates are there. So to sum up, if when we talk about the critical illness, we have already discussed that because of the augmented cardiac output, the leaky capillaries and altered protein binding, the drug concentrations will be lower in the plasma. With end organ dysfunction, there can be the increased plasma concentrations. And when we talk about the extracorporeal therapy per se, again, augmented cardiac output will lead to increased clearance, the hemodilution, the increased volume of distribution will again lead to lowered plasma concentration, and the drug sequestration, more so for the lipophilic drugs, again will lead to lowered plasma concentration. So we have to consider all these factors once we are deciding about what type of antibiotic we are giving and how we have to dose those antibiotics. So let's talk about the individual drugs briefly, like how what we should do. The routinely most commonly used antibiotic is the beta-lactam antibiotic, and they are relatively hydrophilic with varying degrees of protein binding. So recent studies, most of the studies suggest that ECMO does not significantly alter the pharmacokinetics of beta-lactams. And what are recommended are the routine doses strategies for critically ill patients without ECMO can be applied on the ECMO patients also. So as I've already stressed upon, the therapeutic drug monitoring must be always planned to maximize the therapeutic outcomes. The only beta-lactam which has significant protein binding is the ceftriaxone. But again, it does because this increased protein binding up to 95% it is protein bound. There occurs significant circuit drug sequestration, but dosing is recommended is similar to the critically ill patients not on ECMO support. For all other beta-lactams, again, we have to dose similar to the critically ill patients not on ECMO. Vancomycin is another drug which we routinely use. This is again not much sequestered, but ECMO-related increase in the volume of distribution being hydrophilic that occurs and leading on to decrease in the clearance of the drug. So alterations are there in effective vancomycin concentration, but again, studies have suggested that use of continuous vancomycin infusion during ECMO may potentially negate the ECMO-related pharmacokinetic changes. So what we should plan is we should have a continuous infusions of the vancomycin while the patient is on extracorporeal therapy, and higher vancomycin doses might be required if at all we are only going in for intermittent bolus doses rather than continuous vanco infusions. Fluoroquinolones, there is limited pharmacokinetic data available in ECMO patients. The risk of circuit drug loss is relatively low, and especially for ciprofloxacin, almost insignificant. But when we talk about moxifloxacin and levofloxacin, they have lower log P values and similar protein binding properties as compared to ciprofloxacin. Again, degree of sequestration is relatively very low because of the low log P values. So no dosing adjustment required for fluoroquinolones again. For aminoglycosides, they are the concentration dependent antibiotics. They depend upon the concentration achieved beyond the minimum inhibitory MIC values. So also they have minimal circuit sequestration on the extracorporeal circuits. There's certainly increased volume of distribution with gentamicin, associated decrease in clearance is there. So for the aminoglycosides, usually they say during ECMO, there is not much which can be recommended, and we ought to titrate as per the therapeutic drug monitoring only once the patient is on ECMO. So antifungals have conflicting findings. When we talk about voriconazole, it is significantly sequestrated onto the ECMO circuit because of it is significantly almost having 60% of the protein binding is there. And what has been seen that 71% of circuit drug loss occurs because it has a high log P value, like very lipophilic drug and moderate protein binding. So there's an increased need for loading dose, and the maintenance dose also needs to be increased. While another study, it contradicted, it says because time-dependent saturation of the circuit occurs significantly with voriconazole, and supratherapeutic concentrations are achieved when we increase the dose. So we have to always titrate the dose. While for the echinokindins, they have a significant protein binding, although a very low log P value. So 43% loss due to sequestration has been seen in studies. But there is again insufficient and conflicting data, and dosing adjustments have not been very much specified for the antifungals. So considering all these factors, the general recommendations are that all the antifungals, they have a high impact of extracorporeal therapy and likely requires dose adjustment. For the antimicrobials, the potential effects, they potentially require dose adjustment, considering that the loading doses have to be given, and as per the concentration dependent antibiotics or the time-dependent antibiotics. For the time-dependent antibiotics, the infusion doses should be there, rather continuous infusions rather than bolus dosing of the drugs. And almost all other drugs have a minimal and impact, and standard doses are likely appropriate. So beyond the antimicrobials, I wanted to discuss, because these are drugs, other drugs which are commonly used when the patient is on an extracorporeal therapy. They are the benzodiazepines, the sedatives are usually used. So midazolam undergoes significant sequestration, and it has been seen that almost within 1 hour of starting the extracorporeal therapy, half of the drug is lost because of the drug sequestration. So higher initial doses is required to achieve early optimal sedation, and up to 10% increase in daily dose has been recommended for midazolam upon commencement of the extracorporeal therapy. And further, we ought to keep in mind that benzodiazepines, the concomitant organ dysfunction decreases the clearance. So we might need to again modify the doses as per the sedation scores, which can be routinely employed. So requirement, another important thing is that in significant number of studies, it has been seen that requirement is significantly higher in venous ECMO rather than arterial ECMO. So the other drugs used for sedation and for analgesia are the opioids. Fentanyl has a very high degree of lipophilicity, so thereby it is significantly sequestered in the ECMO circuit. And the mean drug loss up to 97%. That 97% of the drug is actually lost in the ECMO circuit, but this is significantly higher as compared to morphine, which has almost nil sequestration, and midazolam is up to 87%. We have just discussed that it is also significantly sequestered by the ECMO circuits. So we need to escalate the fentanyl doses over time to achieve optimal sedation in ECMO. And ECMO, during ECMO, fentanyl might be actually an inferior option as compared to other alternatives available. So morphine effect is lesser, as almost it is not at all sequestered in the ECMO circuit. And average morphine recovery from ECMO circuit even after 24 hours of extracorporeal therapy is more than 99%. So this is certainly a superior clinical option as opposed to fentanyl, but again, we should rather target as per the sedation scores, sedation and even the pain scores. So dexmedetomidine, another important routinely used sedative for the patients in ICU. It has lipophilic nature and so significantly lost through circuit adsorption during ECMO. And within first hour, almost more than 40% of the drug is lost, and up to 70% of the drug is lost by 24 hours of starting the extracorporeal therapy. So we need to have a higher initial dose with higher daily doses to compensate for the anticipated pharmacokinetic changes during ECMO treatment. Propofol, again, it is a highly lipophilic and highly protein-bound drug, so thereby easily sequestered within the ECMO circuit. And significant propofol loss again has been seen. Up to 70% is diminished within first half an hour of starting ECMO therapy, and only about 11% remains after 5 hours. This is what have been studied in the literature. So this is as per the literature only, that after about 5 hours, only 11% of the drug remains in the circuit. Another important thing we have to consider while the patient is on propofol is the oxidation, which can be important determinant for propofol pharmacokinetics. And 70% decrease in propofol concentrations were noted up at 45 minutes post-oxygen exposure. So higher doses of propofol might also be required over time for optimal sedation. So this table actually summarizes the pharmacokinetic changes and potential dosing adjustments needed for the sedatives and analgesics. As I've already discussed, for midazolam, higher initial dose with higher daily doses because significant drug sequestration is there. For dexmedetomidine, again, higher initial doses with higher daily doses are required. For fentanyl, because of excessive drug sequestration, it should considered inferior to the morphine, and morphine should always be preferred. But again, for morphine, we need to give higher initial dose with higher daily doses. Propofol, there is insufficient data, but likely to require higher doses over time because of significant drug sequestration being highly lipophilic and highly protein binding. Another important thing which is routinely used are the anticoagulants. So optimizing anticoagulation in ECMO to prevent ECMO-related bleeding and or thrombosis is mandatory. And this again we titrate as per the our coagulation parameters. But we ought to remember that heparin is again more than half of the administered heparin is cleared by the circuit itself or by the blood components in the circuit. So we might need to give higher heparin doses as compared to other patients. And thereby, there's the importance of material selection also on ECMO-related pharmacokinetic changes for the anticoagulation. Almost for all the other drugs, not significant pharmacokinetic changes have been seen for the other drugs during extracorporeal therapy. So to summarize, this table actually summarizes almost all the things that what we need to keep in mind once the patient is on extracorporeal therapy and what factors they play a role. The pharmacokinetic drug factors, that is the volume of distribution, more so for the hydrophilic drugs, the lipophilicity or the log P, which affects the drug sequestration. Higher is the log P, higher is the protein binding of the drug, more is the sequestration. So volume of distribution important for the initial dosing, the loading doses, the lipophilicity and protein binding affecting the drug sequestration and affecting the maintenance doses, and the clearance, which we all know the renal or the hepatic clearance of the drugs respectively, and their half-life being affected. This we have already discussed, and the ECMO circuit, the circuit tubing and the membrane oxygenators, they do play a role, especially for the sequestration. And the patient factors per se, for all type of patients, the critical illness, the systemic inflammatory response syndrome, what is the end organ dysfunction, the protein hypoproteinemia which occurs, the fluid shifts because of, especially because of the fluid resuscitation, they all affect. We have already discussed how they have an impact upon the drug dosing, and the pharmacodynamics, not only the kinetics, the dynamics, that is whether we are dealing with what is the area under curve and MIC ratio, or for the respective, for the concentration or the time dependent antibiotics, and the time MIC ratio for the time dependent antibiotics, and the Cmax and MIC ratio, or the AUC or MIC ratio for the concentration dependent antibiotics. And we ought to keep in mind that usually the minimum inhibitory concentration is increased. So we always need to have the MIC values for the respective drugs and then target our concentrations accordingly. And all these ultimately we have to consider the critically ill patients not on ECMO. These are the factors which affect. And we ideally, what is recommended is personalized dose with the therapeutic drug monitoring. So to sum up all the things, so drug dosing strategy during ECMO, to initiate, use a high initial dose, especially patients who might be on along with ECMO, the RRT therapy, especially for the hydrophilic drugs. Take into account the patient's body weight, especially for the lipophilic drugs, and do not reduce the dose. Initial dosing, initial loading doses should not be reduced based on the renal function, and loading doses mandatory before starting any prolonged or continuous infusions of the drugs. So during early maintenance dose, optimize the treatment modalities, use a prolonged or continuous infusion for the concentration dependent antibiotics. Do not estimate renal function, right? Use the measured creatinine clearance for 8 hours or 24 hours, because herein the augmented renal clearance plays a role. And for patients who have acute kidney injury, who have a deranged renal function, for all the non-nephrotoxic drugs, they should not be we should not reduce the dose for the non-nephrotoxic drugs during first 24 to 48 hours of starting extracorporeal therapy. For the toxic antibiotics, the nephrotoxic antibiotics, including the vancomycin, colistin, they should be reduced based on the dosing tables which are routinely available. And consider increasing the maintenance dose if we are suspecting the augmented renal clearance. During the late maintenance phase, that is beyond 48 hours of extracorporeal therapy, adapt the dose based upon the residual renal function for the hydrophilic drugs and for the residual hepatic function for the lipophilic drugs. Monitor the plasma exposure based on therapeutic drug monitoring, and adapt the dosing or apply therapeutic drug monitoring when changing in RRT modality, or we are changing the ECMO circuits, because we need to keep in mind the binding site saturations which have already occurred with the aged ECMO circuits, or once we discontinue the ECMO again, we have to alter the dosing strategy we have planned. So way forward is certainly a therapeutic drug monitoring using continuous monitoring devices with biosensors and employing the artificial intelligence and data analysis, and wherein we can be having more precision dosing software leading on to dosing adjustments on a continuous basis. So this is a way long way to go, but before we finally, as of now, we have to keep all those factors in mind which we have discussed: the ECMO related factors, the circuit related factors, the drug related factors which are very important, and the critical illness per se, what type of disease we are dealing with, what is the organ dysfunction, whether it is there in the patient or not. So all these factors have to be considered in as a coagulum, and then we have to decide like how we should change our drug dosings as per the specific drug. So I think I did not make more things complex, but I just try to simplify the things as far as I can. And I hope we become wiser how to dose our drugs during the extracorporeal therapy. Thank you so much.
Thank you, Kawan. Ghanshyam?
Yeah, thank you, Kawal. I think you have touched upon a very, very important but often neglected topic. Many a times we put patients on not just ECMO but other forms of RRTs, and often we find that our patients are not doing well or the sepsis is not getting better. One aspect that we should always consider is whether the antibiotic dosing is appropriate or not. And that is what something, if you look at the majority of the trials where they used high volume hemofiltration, one of the biggest finding was that the clearance of not just antibiotics, but a lot of other, vital components like trace elements, vitamins, amino acids, etc., are lost during extracorporeal therapies. So that is something that we need to keep in mind. So, my own understanding is many a times it's going to be very, very difficult to get the drug dosing right. So you are likely to make an error, and if you are likely to err, preferably err on the side of higher dosing than lower dosing. That's what I understand. Srinivas.
Yeah, thanks, Ghanshyam. I think it was a very crisp and eye-opening talk. All intensivists actually need to understand this. It's not just prescribing based on some fixed formula for all patients. It has to be a dynamic assessment, maybe more than once or twice a day. So two things which will add to this is the availability of therapeutic drug monitoring. That is going to be the future of personalized prescriptions in the ICU. And if you combine this with an AI algorithm, I think prescription of life-saving drugs can become much safer for all critical ill patients. The X team is actually bringing out a book on ICU pharmacology, specifically focusing on such issues and topics, and dedicated sections on drug dosing. Every drug, what is the disposition on extracorporeal circuits we are going to. So please look forward to this announcement very soon. A good team of highly knowledgeable and efficient authors are authoring this book. So we look forward to your patronage as we have worked for the book on algorithms in healthcare. Thank you all for joining us today. If you have any questions, queries on this topic, please do post them on the group from where you got the link from, and we will answer them at the earliest. Have a good day, and please do register for the 10th edition of PICS from June 19th to 22nd. very few slots open still. See you all in Hyderabad. We'll meet again next week with another topic on the Higgs Tuesday academic program. Thank you and bye-bye.
Thank you, sir. Thank you.
Thank you. Thank you, Kawal.
Thank you. Bye.